Hello, this is Kim McCleary. I'm President and CEO of the CFS Association, and I'm delighted to welcome everyone to our 22nd webinar. We have great registration for today's program. Almost 500 people have registered, and I can see the number of attendees that are joining us growing. We have two tremendous speakers with us this afternoon, and a topic of obviously great interest given the response to this particular program. So we are recording today's program. It looks like it's the recording is working, so we'll be able to post this later this afternoon, and we'll also make the slides available. If this is your first webinar, take note of the control panel on the right side of your screen that has some different features. You can submit questions and do some other things via the control panel you see there, or you can minimize it to get it out of the way so you can see the slides in their full glory, if you will. Okay. I'm just going to go through a few housekeeping details before I introduce our speakers this afternoon. Again, this is Kim McCleary. I'm President and CEO of the CFS Association of America, and this is our 22nd webinar. We started a webinar series in 2010 and have been able to extend it and intend to have several more programs this year. This is the second one that we've held in 2012. And we have been able to make almost all of those recordings available. They are posted in our YouTube channel, and I've provided the URL for that right there. You can also just go to YouTube and search Solve CFS and should find our channel with most of those programs recorded. We had, as of last time I checked, 493 registrants this afternoon, which is a tremendous turnout. We thank everybody for participating today. And just as a reminder, we know that you can't see us. You should know that we can't see you. There aren't any hidden webcams projecting you into our screens. And of importance is that we can't see each other, and we're in 3 different locations. So we don't have the benefit of body language, hand signals, or you know, that sort of cut it off sign that people make when they're in person to let the other speaker know it's time for them to be quiet because somebody else has a point to make. So just bear with us as 3 of us try to exchange typed comments or comments back and forth in audio to let each other know that we're ready to move on. As I had indicated, we are recording this program. The slides will be posted online. We'll put those on our Research First site and also up on the YouTube channel for the recording. We gave registrants the opportunity to submit questions with the registration, and we received more than 100 questions. So Dr. Vernon and Dr. Lange have been gracious and have been reworking their presentation all week to try to incorporate some of those questions into the program, and then we'll take as many as we have time for at the end. If you have a question that comes up during the program, feel free to submit it using the chat feature on your controls panel. While they are delivering the presentation, I will be fielding as many of those as I can comfortably during the program, and then I will forward those on that I don't have answers to our speakers, and we'll try to get to those at the end. But it's unlikely that we'll be able to get to everybody's questions, and certainly the more specific ones to your medical situation, we just aren't in a position to answer. We also plan to use some polls to interact with our audience so that we can gauge some of your interests and experiences across the sort of normed data that we have from research studies. So we hope that will be an added feature that you'll enjoy taking part in as we go through. Now it's my pleasure to introduce Dr. Goodwin Lange, and I'll introduce Dr. Suzanne Vernon as well, and then I will let them deliver the program in sort of a tag team approach. They're actually going to share one set of slides so that we don't have to transfer the controls back and forth too many times. Hopefully that will work out comfortably. Dr. Lange has been involved in CFS care and research since 1995. She is a professor at New Jersey Medical College and also the UMDNJ, University of Medicine and Dentistry in New Jersey. And she also holds an appointment as a research scientist at the VA War-Related Illness and Injury Study Center, where she works with a lot of veterans who have many of the same cognitive problems that CFS patients do. So her research is doubly important and really comes from that, studying those two populations quite closely. Dr. Suzanne Vernon is the Scientific Director of the CFS Association of America, my partner in crime, as we like to say. She has also been studying CFS since about 1996 and joined our staff in 2007 after having been at the Centers for Disease Control and Prevention and their CFS research program, leading the laboratory effort there. And Suzanne has just made tremendous contributions to the association and our work since joining our staff 4.5 years ago, most notably the launch of the Research Institute Without Walls that was the topic of our webinar in March. So now I am going to do the, hopefully the seamless trick of transferring the controls over to Gudrun so that she can take it away with her presentation. And you should see sort of a temporary screen there, and then we will see Dr. Lange's presentation, and it looks like that.
Okay.
So go
Did
for
it
it,
work?
Gudrun.
Very seamless. Perfect.
Excellent. So good afternoon, everybody. As Kim said, my name is Gudrun Lange, and I have the distinct pleasure of spending this afternoon together with you all and Dr. Suzanne Vernon. I'm the first presenter, so I'm going to go moving right along. First, the pretty obligatory disclaimer that all views expressed in this presentation are my opinion only, and only my opinion, and not of the Department of Veterans Affairs or any other government entity or the University of Medicine and Dentistry in New Jersey. What we're going to talk about today is going to cover the following topics. In general, we want to talk to you about what we know about cognitive functioning chronic fatigue syndrome, and we thought it might be an interesting way of presenting it from different perspectives, from the patient's perspective, the researcher's perspective, the clinician's perspective, and also from the Social Security Administration's perspective. And then we'll come up with a bottom line and then open it up to questions. As Kim said, we are going to try and keep this very informal, so I expect Suzanne to interrupt me and perhaps Kim as well if something pertinent wasn't covered or some burning question pops up that they have heard chronic fatigue syndrome patients ask.
Will do.
Okay.
Your wishes are command.
So let's talk about brain fog. Individuals suffering from chronic fatigue syndrome often describe their cognitive difficulties as brain fog. Here are some common quotes that I hear a lot. I feel that my head is in a bag of cotton balls. I feel like I'm losing my mind. I have the brain of an 80-year-old person, and I'm only 36. Although men and women with chronic fatigue syndrome come from all walks of life and social strata, the sense of loss of control, function, and quality of life due to the cognitive difficulties they experience is really the great equalizer. Here are two vignettes based on my patients I've seen in my practice. A 42-year-old homemaker reported that, I used to cook exciting gourmet meals for my family. Now I cannot follow the recipes in my cookbook anymore. When I'm up to it, I'm able to boil eggs. I feel useless sometimes and feel like a burden to my family. A 58-year-old lawyer. I still am a successful lawyer. By 11 a.m. I'm so fatigued, I nap under my desk or in the bathroom. I prefer phone conferences to face-to-face meetings now because I can make notes for myself. I have several volumes of memory books now, but my notes have become a lot spottier over the recent past. I used to deal with a number of cases at a time. Now I'm looking for excuses to avoid that. My boss has noticed that my performance has gone down, and I'm afraid I'll lose my job. As you can see from those two vignettes, the chronic fatigue syndrome touches many different patients. And reports similar to these two vignettes that I just read are not uncommon in this patient population. Here are the cognitive complaints most commonly reported by chronic fatigue syndrome patients. And let me just say, I'm just using chronic fatigue syndrome as a general term for CFS-ME. Concentration and attention problems are the #1 issue. I have trouble reading a book. I have to read the same paragraph over and over again. How many of you have experienced that? I bet quite a bit. Memory difficulties. I go shopping for food. Once I get to the food store, I cannot remember what I needed. I think I'm dementing. Again, I hear this so many times. The good part is you're probably not dementing. Word-finding difficulties. I'm not going out anymore. I cannot keep up with the conversation. I cannot find the right words quickly. By the time I do, the conversation has moved on. And for those of you who have not experienced word-finding difficulties, it's similar to when you, let's say, travel to France and you spend time with your French friends and they forget that your French isn't so good. And they talk and talk in French and have a good time, and you get one part of the sentence and you formulate the answer, but by the time you can say it, they're already on the next topic. That's kind of how that feels like. I can't think. That's really a very common complaint. I used to be so sharp. Now I cannot figure out how to make a decision. I'm so stupid now. Good part here is we know you're not stupid. I'm going to turn this over to Dr. Vernon now, who's going to talk about symptom severity.
Can you see my cursor, Gudrun, Kim?
Yes?
Okay, super.
You're in control.
I'm in control. Oh, those were very heart-wrenching vignettes that you shared with us. And as you see from this graph, concentration problems and severity, this blue bar here, are one of the most common and the most severe symptom that are reported by patients. This is the result of a survey that we did online last year, and this was 2,000 respondents. And almost in every age category, except for the greater than 55, where it becomes the second most common and severe symptom, brain fog, concentration problems is reported as being the most disturbing and severe by the majority of people throughout all ages.
Suzanne, do you want me to launch the poll on the symptoms for this audience?
Oh, that would be great.
Okay.
So everybody, Kim's going to launch a survey. Now it's your turn to press these buttons. Is it select one of the following? Yep. Which of these symptoms is most problematic for you day to day? Select one and then hit the submit button. We'll give a couple of minutes, minute or two.
I can
Are you able to tell when the poll is complete, Kim?
Yes, I have 51% have voted already. And we recognize that there's somewhat of a selection bias in this audience since you are here out of interest in the cognitive issues. So it probably won't be surprising if concentration and memory problems rise to the top. But it's
And
a
we're
great
also only allowed a limited number of symptoms, right?
right. There are only 5 choices you can make on these polls, so we had to be very judicious as we wrestled with one another over which things to include. Okay, we are at about, let's see, once we get to 80%, I will close it. Couple more people, then we'll be at.
We're going to be having a post-exertion malaise webinar soon, aren't we, Kim?
We're going to certainly try to get that one. That is a topic also of tremendous interest. Okay, we're at 79%, so I'm going to close it and share the results so everybody can see this. Can you see it, Suzanne, the results?
Yep.
Okay, great.
47% report concentration and memory problems, 33% relapse of symptoms after physical or mental exertion, 6% muscle and or pain, joint pain, 12% unrefreshing sleep, 2% sensitive to light, noise, and odors. That's interesting that the unrefreshing sleep is 12%. But again, go ahead, I'm sorry.
We you know, you had to, we asked them to make a sort of Sophie's choice.
That's right. It's just one. And you already said that this is a biased poll, so perhaps not surprising, but interesting nonetheless.
Okay, so I'll close that.
Thank you, everybody.
Thank you. Yeah, that's a great tool. Okay.
Suzanne, do you need me to scroll down the slides?
I don't know. Let me see if I can do it. I'm going to hit page down right now. And I guess I do, Gudrun.
You do?
Yeah.
Oh, here. Mm-hmm.
Okay, so let's try to get into the... sorry.
Life goes on.
I'm going to mute me for a sec.
Okay, so Dr. Vernon is now going to talk about research findings in chronic fatigue syndrome, and she's going to concentrate her presentation on neuroimaging findings, because over the past few years the number of neuroimaging studies in CFS has grown tremendously, while the number of behavioral studies has actually trickled to 0 almost. So I don't know whether Dr. Vernon is back.
Suzanne?
Okay, I'm back. Sorry about that. I am back now. Can you hear me?
Yes.
Sorry about that. And I was busy trying to unplug this phone, and so I'm not sure I caught everything that you said, Gudrun. But what I'd like to do now for the next couple of slides is just give some of the research perspective on what has been identified as going on in the central nervous system, particularly with some neuroimaging studies. I'll first start out by describing some of the work that's been done to try to identify whether or not there are morphologic changes, or that is changes in the structure of the brain in people with CFS, particularly certain types of brain lesions or brain volume. And let's start with this little diagram up at the top, just so that you're familiar with some of the brain anatomy. Gudrun, can you see my pointer?
Yes.
Okay. So the outside of the brain, or this kind of folded structure that you see, is called the gray matter, and that actually contains the cell bodies, the nerve cell bodies, and a lot of the blood supply to the brain. The white matter contains the long sheaths of the nerves, or what are known as axons. And later on in the presentation, you'll see a really cool new type of imaging technique that's actually able to capture the morphology of the nerves very nicely. But in CFS, what has been shown is that there are some nonspecific small white lesions in the frontal lobe, and these have been related to impairments in physical function. Gudrun, wasn't this your work?
Yes. Mm-hmm.
Would you like to describe a little bit more about that?
Yes. This study we've done in the early 2000s and was one of our first studies. And when Dr. Vernon said non-specific small white matter lesions, the frequency of these white matter lesions were on average 8 little specks of white matter lesions. That, if you look at that compared to what we find in multiple sclerosis, for instance, where we have 10, 20, 30 small white matter lesions around the ventricles, this is a very small finding. Nonetheless, it was significantly different from our control group. So when I see patients, many times they ask me, well, do you think it's worthwhile to go and have a brain scan done because of this finding? And I always say it's unlikely that your radiologist will see anything in a static picture because, number one, there aren't that many white matter lesions that we are expecting, and number two, the research data is group data, so it's very difficult to compare an individual's data to this group. There are no standards, radiological standards I know of, for static neuroimaging pictures concerning CFS.
Mm-hmm. Importantly, too, we don't really have very extensive baseline data for these types of lesions either, do we?
No, we don't.
Okay. So this image on the right is actually an image done, an imaging study done by the Japanese, which shows some loss of gray matter. So the cell body, or the outside part of the brain, this very folded structure. And what they found, and a few other studies have found, is loss in gray matter, and that's indicated by these red and yellow highlighted regions, which is actually a statistical tool showing, again, as you average all of the pictures that you take of people's brains, what is the difference in these various areas between or among all of these people. There's also been some studies that have shown a loss in white matter. Again, that's the inside part or underneath the gray matter and the axons. Now, it's important to realize that not all imaging studies have found these differences, so it's been inconsistent, and oftentimes there's no differences when controlling for psychologic and psychiatric comorbidity. You have anything else to add on this slide, Gudrun?
No, I think you really mentioned all the important points. One of the really important ones that one should take away from this slide is that these findings are not consistent, right, and depend on the research team that does the study, how they define CFS, whether they look at
Gudrun?
morbidities with depressive disorder, and yeah. Hello?
Yeah, I think you faded out a little bit, so.
Oh, okay.
I
So,
have
go ahead.
one question that came in. What is DLFC? That you might be able to...
Dorsolateral frontal cortex. Sorry about that.
Gudrun and I have been going back and forth with these slides now for the past week, and we tried to make sure that we caught all of those things, but we're likely to run into a few more. So if you can go to the next slide, Gudrun.
Okay, but I'm glad people ask. Okay.
A lot of studies have looked at brain metabolism, and this is another type of neuroimaging technique which actually is non-invasive, as are many of the neuroimaging techniques, not all, but many, and it detects some of the chemical differences using kind of the magnetic resonance of the water molecules in the brain. So this first picture to the right here, that is a side shot of a brain, and it has this red space in the middle with the yellow bar, is actually trying to detect differences in a number of chemicals in the cerebral spinal fluid, which is right inside this ventricular space here. And what these investigators found, and these are investigators that many of you are probably familiar with, Tacoma Shungu, actually Dr. Nadelson, Ben Nadelson, and a number of others up at in New York City, showed that there was increased ventricular lactate, or lactic acid right here. They described it as brain burn in CFS patients. But importantly, not only was this increased lactate found in CFS patients, it was also found in patients with major depressive disorder. Both CFS patients and patients with major depressive disorder had increased ventricular lactate, or lactate in the cerebral spinal fluid in the brain, compared to healthy controls. They also looked at ATP, the energy molecule, throughout the brain, again in both CFS and major depressive disorder patients in comparison to healthy controls. And interestingly, we actually did not anticipate this finding, they found that there were no differences in ATP in the brain of CFS, major depressive disorder, and healthy controls, all the same level in all three comparison groups. And finally, one of the most recent findings is they found decreased glutathione, one of the brain's most powerful antioxidant molecules, in the brain of both CFS and major depressive disorder patients compared to healthy controls. And this finding right here, this is actually in the a different part of the brain, the occipital cortex, a region of the brain that's important for vision. But again, there was decreased glutathione in both the disease groups, in CFS and in major depressive disorder, compared to healthy controls. So if one was trying to say that, you know, lactic acid or lactate is diagnostic for CFS, we couldn't say that because it was actually the same in the major depressive disorder. If one was to try to say the same thing for glutathione, it also, we couldn't say that either because it was the same in major depressive disorder and CFS. And I think what this indicates is that there's some similar pathophysiology going on in these chronic disorders. This one, the glutathione, indicating an increased oxidative stress state in the brain, as does this one, indicating increased oxidative stress and perhaps also increased inflammatory processes going on.
So Suzanne, I just have a question. So these brain metabolic studies, are they speaking toward the energy level in the brain in chemical terms?
For the ATP findings, they were speaking or looking at the energy level and specifically trying to get at whether or not the mitochondria were functioning differently in the brain. And the ATP finding would suggest that the mitochondria are functioning similar, at least utilizing energy in a similar fashion. Mm-hmm. But the lactate and the glutathione findings would indicate that there's some type of subtle kind of instigation going on there. as evidenced by the increased lactate, which would suggest perhaps some type of inflammatory process going on, and that could very well be an inflammatory process in the periphery instigating this increased lactate, and then the decreased glutathione showing that there's this not so good antioxidant state, and that's a very important state to have. So while the mitochondria might be behaving similarly as far as using the energy, they might be responding a little bit differently to some of the stimuli that's occurring in these chronic disorders.
Mm-hmm.
Does that make sense?
Yes, so it would actually be an interesting thing to do a study where you look at brain metabolism the way that was looked at here, and potentially white matter lesions to see whether there might be some more supportive evidence for inflammation, let's say.
That's a very good point. I wonder if they actually might even have that data, because most of these studies actually take some type of morphologic and volumetric assessment when they're doing this.
Yeah, most people do volumes, right. So that's a note for us on the investigator and clinician side to look that up and share it with the community.
That sounds like a good idea. Kim, are you writing this down? Or are you busy taking notes from questions that are coming in? I'm looking for a piece of paper right now.
I am busy typing answers.
One question came in that said, what type of imaging is used for these studies? And if we didn't address this, I apologize. But many of these studies that Suzanne is talking about, especially the static ones and the ones that will follow, are magnetic resonance imaging studies, and they are done in MRI machines, magnetic resonance imaging machines. Many of our listeners probably already know, and they are of different strengths, either 1.5 Tesla or 3 Tesla, the newer machines, and that's the magnetic strengths of the machine. So the higher the Tesla, the better the picture. And then we also have another acquisition mode, which is by PET scanning, and a lot of the metabolic studies are done with PET or SPECT scanning, and I'm pretty sure that our audience members have heard of that, because some providers suggest to have PET or SPECT scans done to look at brain function, but I think the ones that you presented here, Suzanne, they're all MRIs, right?
That is correct. These are all MRIs.
Do you want me to launch the poll about the different types of tests that the people participating in today's webinar have had?
Not yet.
Okay.
Not yet.
All right.
Let's get through these. I think there's 2 more new neuroimaging slides. Let's move on to the next one. Another neuroimaging technique is functional neuroimaging, and that's different than the magnetic resonance spectroscopy, which you saw on the previous slide, and that during functional neuroimaging, the person is in the magnet or in the imaging machine, and they are presented with either with certain types of stimuli. They're either asked to look at pictures or do certain types of tasks, so that the machine, the imaging device, actually picks up the activation from that stimuli because of blood flow in the brain. So in this technique, blood is being used as a surrogate or a proxy measure of the neuronal activity. There's been quite a number of fMRI, or functional neuroimaging studies, done in CFS, and they've shown in general that people with CFS use more regions of the verbal working memory network, that people with CFS, and this is an important point, actually perform as accurately as controls, and their behavioral performance is the same as controls. So this gets at an important point that their effort, most of the time, the effort in CFS patients and controls is identical. You want to say anything more to that, Gudrun?
Yeah, that's a really important point, because a lot of our patients come in and say, somebody told me, I'm just making this up, that I can't do this anymore, I can't balance my checkbook anymore, I have trouble driving, all those types of things. And then when they go to a neuropsychologist and do some cognitive testing, when the results are not favorable, then sometimes it's interpreted that the individual did not put forward enough effort, and so the patient is basically blamed for his or her deficit. With our study looking at working memory function in chronic fatigue patients compared to controls, we clearly established in the magnet that CFS patients behaviorally can do the same work as healthy individuals, and that in the brain they show robust activation in the same areas as the healthy individuals, only in addition they also show activation in the back part of the head. So when you put your hand in the middle of your head, move it slightly backwards. That's your parietal lobe, and that is where an accessory attention network is located. And what we found is that patients suffering from CFS are activating this posterior attentional network, and then perform pretty much like normal controls. However, they do perform slower, and that is where the crux of the matter is. Patients with CFS can do the intellectual work just as well as healthy controls if they have enough time, at least in our study.
Interesting, and we'll start talking about some of those systems, the cognitive systems that are most disturbed in just a bit. This image below is an fMRI image, and the blue bars are the healthy controls, the CFS are in red, and this image here shows that when it comes to actual error processing, so this particular study, there was a task that was given, and the errors, the number of errors were counted up. There's really no difference between the healthy controls and the CFS. So this was a relatively difficult task, and both CFS and healthies performed the same. And this region of the brain was activated, similarly in both control groups. However, if you go over here, this is a little bit different part of the brain, the recognition or the acknowledgement of those errors being processed is actually a lot less in CFS. Now this actually might come to the point that Gudrun was just making, that the processing, the realization that those errors were made may in fact be a lot slower.
Yeah, maybe
that's one interpretation of this. But this is an example of how fMRI can actually capture these types of cognitive differences that we know exist in CFS patients. Okay,
somebody,
move on to the next slide.
Actually, somebody has asked what B and D represent in that last slide. Are those just two time points, two different brains?
B and D are the graphs. So these are the number of errors. Okay, this is an error estimate. So again, this is a functional imaging task. So the healthies and the CFS are in the magnets, and this is basically an average signal. So it shows no difference between healthy people and controls in the error processing rate in healthies and controls. And over here in D, both the image and the graph, shows that the recognition of that error processing is in fact reversed. It's not realized in people with CFS. And this could be because of perhaps the delayed processing that Gudrun was talking about. There's been a lot of work using neuroimaging to assess cerebral blood flow. And again, this is the blood to your brain is important. Your brain needs oxygen in order to be able to function appropriately. It's where the energy comes from. It's basically what keeps the tissues alive and functioning well. The majority of studies that have looked at cerebral blood flow have in fact shown that there's decreased blood flow in the brain of CFS patients. This is called hypoperfusion in CFS. And it's important to know that this is when the study controlled for psychologic and psychiatric comorbidities, that this global reduction in cerebral blood flow is shown. And again, this is an MRI or a magnetic resonance study that actually showed the regions of the brain that had decreased cerebral blood flow. And this is, again, a study that was done by Tacoma Shangu and Ben Nadelson and Matthew Sanjay Matthew.
Right, and the areas here, this is the dorsolateral frontal cortex, as we've talked about before. This is the cingulate. These are areas that are very, very prominent in cognitive function. And importantly, I'd like to add to what Suzanne was saying. Very recently, studies, we have been able to measure absolute cerebral blood flow, supporting data that we've had from measuring relative cerebral blood flow. And that's an important methodological step, because relative cerebral blood flow is reliant on comparison with another part of the brain that in ill people, chronically ill people, could also be abnormal. So while the evidence suggested very strongly that there is hypoperfusion in the brains of chronic fatigue syndrome patients, it now has really been, in my mind, supported very, very strongly by these absolute cerebral blood flow studies using specific MRI methods that are also non-invasive and show the same thing. And it tends to be pretty much, when you get these images done, the hypoperfusion seems to be pretty much across the brain. And the little yellow spots that you see here that Suzanne showed you, we get those by really massaging the data strongly in a statistical way. So I think I'm most comfortable saying that there is global hypoperfusion in CFS, most likely in the frontal lobes, but here's the caveat. That also happens in other disorders like mild traumatic brain injury or other acquired brain traumas or brain injuries. Just an aside, an acquired brain injury can be categorized in different ways. A stroke is an acquired brain injury, or a traumatic brain injury, when you have a car accident, for instance, is an acquired brain injury. So a lot of the more subtle acquired brain injury conditions have a similar hypoperfusion picture.
Do you know if there's been any studies done on brain perfusion in encephalitis?
No, I'm not aware of it.
Like Nile or something like that? That would be interesting.
I'm not aware of it. We might want to look in the Australian literature, but I don't recall anything.
You know what else is interesting, Gudrun, is that the cerebral blood flow studies that I'm most familiar with is, using the tilt table, and they tilt people up and they show that the blood flow doesn't go to the brain very, very adequately or well. And these studies, these imaging studies, are actually done while the person's laying down. So there's, right?
What did you say? I didn't catch that, Suzanne.
These imaging studies are, the person is laying down, so they're not even in an upright tilt position. They're actually laying down.
That's right, and we try to recreate some of these orthostatic challenges in the scanner, and some people are doing it right now. I think Dr. Cook in Wisconsin is trying something like that, and some people here in New York as well, to equate the orthostatic challenge with the cognitive function and the brain physiology. Mm-hmm. So that's ongoing work.
Well, let's move forward, because we're chatting an awful lot here, but it is fun. This is a kind of a summary diagram that Gudrun actually put together here on the left, and on the right is a schematic that I took from a Nature Neuroscience paper, which actually describes the parts of the brain, and then at the bottom here underneath, it describes the parts of the brain that are important for attention, working memory, and executive function. Again, the cognitive functions that we will hear in just a bit are also perturbed in CFS patients. But and this actually, if you follow my pointer, the attention, working memory, and executive functions follow this path, kind of the green parts in this schematic. And if you go over to how Gudrun has summarized the neuroimaging findings, many of them overlay some of the same regions. So while it's not a scientific validation of these neuroimaging findings, it certainly is interesting and somewhat, comforting is not the right word, but it's good to see that there are some of these neuroimaging findings that overlap with what we know is in charge or responsible in the brain for having good cognitive function in the areas of attention, memory, and executive function.
Right, and I just see two questions popping up, Suzanne. One is how were the patients diagnosed in the studies that we are presenting? When we were preparing this, I made sure that everybody in the studies that I summarize in this slide on the left was diagnosed with the 1994 criteria. I know that there is discussion out there about which criteria to use, but for the purposes of research, the 1994 criteria are the ones that are used most commonly and we have most data with. So I think that using that is quite appropriate. Then what is ANS is another question, and maybe Suzanne, you could briefly go into that. It's the autonomic nervous system, and what does it do and which area of the brain is associated with that at the slide here.
Ooh.
It would be the insula, yeah.
Okay.
Sorry, because
you put me on the spot.
I'm sorry. So it would be the insula, so the insula controls blood pressure and other functions associated with the autonomic nervous system. Mm-hmm. And I'm not a physiologist, I'm a neuropsychologist, so I don't know too much about heart rate and blood pressure, but working with investigators that do look at that, I know it's an issue in CFS.
That's right. And a lot of the autonomic nervous system dysfunction is associated with brain fog issues or concentration issues.
Right.
So again, the connection is there, and it's an interesting one. Okay, let's move on.
Absolutely. Okay.
It's important to realize that there are limitations to many of these neuroimaging studies. Although again, it's comforting to see that there is some consistency. Nevertheless, many of the sample sizes are small, and as somebody already brought up, oftentimes case definitions are not consistently applied or used between studies. There's also some different stratification used. Some studies included subjects with psychologic and psychiatric comorbidities versus those that did not have any of those. And another thing is inappropriate healthy control groups. For example, physical conditions. Some of the findings have shown that there are different neuroimaging results based on the physical condition that you're in. So it's important to use that as criteria when considering the types of control groups. And many of the studies, importantly, did not use a disease control group. As you saw in the metabolic findings studies and also the blood flow findings, that they're actually not the blood flow findings, just the metabolic findings. They used a major depressive disorder control group, and there were no differences between CFS patients and MDDs. So it's very important to try to include the appropriate disease control groups in many of these studies in order to have the best interpretation of the findings. And there's a wide array of non-standardized self-report instruments that we use to assess CFS patients for studies, as well as neuropsychologic assessments. Again, none of this has really been standardized, particularly in CFS, but the good news is we're working on trying to get standard instruments in order to overcome this particular limitation. And finally, there are a lot of technologic and analytical limitations of neuroimaging. I was reading one paper that actually came out recently. It called fMRI blobology. That it's the art of comparing one blob to another blob. I think again as Gudrun mentioned, as we improve the resolution and the magnetic power, if you will, of some of these imaging devices, a lot of these limitations we will be able to overcome. So you always have to consider these. And I think that the other good thing is that, in fact, many of the neuroimaging findings are pointing at regions that we know are pointing at areas of cognition that we know are altered in people with CFS. And we're going to summarize this by just going through a meta-analysis paper. A meta-analysis is when the investigators look at all the literature on a certain topic, and in this case it was cognition or cognitive impairment in CFS. They were able to identify, of the several thousand studies that they looked at, 50 studies that actually met the criteria for their meta-analysis, and this included 1,544 CFS patients and 1,487 controls. The bad news is that the 50 studies used 80 different cognitive tests with 79 different scores. So that's certainly a limitation, again, highlights the limitation of assessing cognitive function using this neuropsychiatric testing that Gudrun's going to talk about in just a bit. But the good news is that 24 of the 80 test scores met criteria for impairment. And that means that they actually had tests or assessments of attention, memory, reaction time, motor functioning, and verbal abilities. And what the findings of this meta-analysis showed is that impairments identified with objective testing using neuropsychiatric or neuropsychologic assessment were consistent with the reported memory and concentration problems that patients report in general, going back to that graph that we showed in the beginning. The objective deficits occurred in the areas of attention, memory, reaction time, and processing speed. And these are things that Gudrun mentioned when we were talking about the neuroimaging studies. So again, we're seeing some consistency between neuroimaging and cognitive assessment. Particularly, the processing speed becomes a problem, as does reaction time, particularly when the information is more complex. The good news is CFS does not appear to impact perceptual abilities, fine motor speed, language, reasoning, or intelligence. All of those things are relatively normal when compared to healthy controls in CFS patients. More cognitive impairment is actually seen in CFS patients that report sudden onset and for people without coexisting psychiatric disorders as well as coexisting fibromyalgia. The next slide shows a summary of the cognitive domains that were assessed in those 50 studies and showed that the most consistent finding in CFS patients is an effect on reaction time and attention, and also borderline motor functioning. This gets at the reaction time and the processing speed. Is that right, Gudrun?
Yes. Mm-hmm.
And I think you're on now for the
Yes.
next slide.
So now I'm turning from the researcher's perspective that Suzanne so nicely presented to the clinician's perspective. Once a patient undergoes a neuropsychological exam, the neuropsychologist is most likely to find subtle and relative deficits in information processing efficiency, working memory, and executive function, as Suzanne pointed out on the previous slide. What are all these terms? Efficient information processing sounds very highfalutin. Well, it really refers to decreased thinking speed. Many patients report, I used to be just Johnny on the spot, quick, 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 and now it's like molasses in my brain. I'm going to get it very soon, but not quite yet. So that's inefficient information processing. That's the number one function that is affected. Ability to keep information online, that is what is referred to when we talk about working memory. So what the ability to keep information online is interacting with efficiency of information processing. If you are slower getting the information in, then you will get less information in, if that makes sense. So you have less information to work with. So some people report that they have memory problems. Well, memory problems per se we generally do not find in our CFS patients, but it is perceived as a memory problem when you can't remember all the information you thought you had taken in. And that is often due to the slowness of the information processing and therefore the more cumbersome working memory process that is going on. Sequencing is another issue that is loosely captured under executive function, and that means you have to be able to almost automatically make a set of assumptions in a serial manner to be able to make quick decisions. While you make these assumptions, you have to simultaneously prioritize which ones are more important than others. For those of us who are healthy, who don't have a chronic illness, this is an almost automatic process. And even though it does rely on education, many people who did not go to college or to university for 12 years are really good at that. And this is one process that is often noted by patients with chronic fatigue syndrome as getting worse. They have a hard time making decisions. that doesn't know that you don't know how to make a decision. It's just that you can't make a decision as quickly as you used to or as you'd like to. Importantly, if you look at the bottom of the slide, earlier in the day, I said that the good news is that you are neither stupid nor dementing, most likely, and that refers to overall intellectual function. Generally, there is no decrease in overall intellectual function. In general, we can say that chronic fatigue syndrome is not a neurodegenerative disorder such as Alzheimer's, for instance. The profile is quite different in Alzheimer's disorder and quite distinct, as are the profiles for stroke, which is an acquired acquired brain injury, or other neurodegenerative disorders such as other dementias. The profile is very different for those conditions.
Hey, Gudrun, Kim, are you there?
Yep.
I'm here.
Okay.
Yep. Mm-hmm.
Do you want to run that poll? We breezed through the testing, I think.
Okay.
Before Gudrun goes on.
Yes.
Yeah.
Okay, so hopefully everyone is seeing a poll that reads, what kinds of testing have you had done since getting diagnosed with CFS? And we do recognize that there are some people on the webinar today who don't themselves have CFS, so don't feel obligated to respond, and we won't wait for 100% response on these polls, knowing that they won't apply to everyone. And as I typed in the chat box, please don't get too concerned about the way these questions are asked. It's a limited format, and we had to do the best we could with the way that the software works. They aren't going to be used for anything more than to inform our discussion today. So please don't take them too seriously. They're for entertainment purposes only, if you will.
Gudrun, when some of the cognitive assessment studies that I've read and participated in when I was at CDC,
Mm-hmm.
They found that it was really hard to find a neuropsychologic assessment tool that would differentiate people with CFS from kind of the healthy population. And one interpretation of this is that people with CFS are just too smart. I mean, they don't, as you indicated, suffer from any intellectual deficits.
Right, but they do suffer from slowed information processing.
Mm-hmm.
So when somebody undergoes a neuropsychological evaluation, the neuropsychologist has to pay attention to this issue and then interpret it appropriately. Mm-hmm. Some clinicians out there are not familiar with the literature in CFS, so they might look at the wrong thing. Other clinicians, and I'm going to go into that at the next slide. Can I move the slides now that you take the poll?
Okay, let me close the poll and we'll see the results. So MRI seems to be the most popular, with other vocational tests of IQ or memory.
Look at the, 35% for tests for information processing, speed, accuracy, etc. That's pretty significant.
I can't see the poll, but I'm taking your word. So what were the numbers?
So for MRI, it's 59%. For SPECT, 12%. Functional MRI, 3%. Tests for information processing, 35%. Other vocational tests of IQ or memory, 44%.
And the question was?
What kinds of testing have you done since getting diagnosed with CFS?
That's
and
amazing.
They were able to select more than one.
Yes.
That's amazing. So that means 71% had a neuroimaging test done.
Mm-hmm.
Oh, some people might have both of them, so maybe it's, you know.
Yeah.
That's amazing.
It's more than half. More than half have had some kind of imaging done.
Well, I'm going to address that in a little while.
Okay.
So I'm just going to put that on a piece of paper aside. So let me just go into why, to answer your question more thoroughly, Suzanne, why it is very difficult to find a deficit in patients with chronic fatigue syndrome. As I said earlier in the program, the deficits or the dysfunction that we see is fairly subtle. The research community has made a statistical decision, and correct me if I'm wrong, Suzanne, I think that's a pretty sort of, I don't know where it's written, that we have to do plus minus standard deviations to declare an impairment. Mm-hmm. I think that's kind of an arbitrary decision somebody made, but nevertheless, often arbitrary decisions become written in stone. And so many clinicians out there, and also a lot of normative data that is contained in the manuals of neuropsych tests, declare that plus minus 2 standard deviations is an impairment. Now, the deficits that we see in chronic fatigue syndrome never reach that significance, never reach that severity. To give you an example, in my experience, people that have that are below 2 standard deviations on a test have either had a severe traumatic brain injury, that means they had a Glasgow Coma scale of 3 or 4 max on a scale of 13, and that's a scale when you're in a car accident and the EMT comes, they take this measure to see how aware you are, how much with it you are, and these are severely affected people. Also, 2 standard deviations below the mean, I would see stroke patients that may be having verbal difficulties in that realm, but these are really severely impaired patients. We don't see that in chronic fatigue syndrome. So to look at absolute impairment measures as the one that I just talked about is not the appropriate thing. Instead, we have to look at relative deficits. I said earlier that our patients are intellectually, most of them are not intellectually impaired. So they're intellectually functioning, they're intellectually intact. As a matter of fact, many of our patients are above the average intellectually. So that is our baseline. Your overall intellectual function is our baseline to look at what your relative deficit is. So if you look at a number and you say, let's just say for argument's sake, your intellectual function equates a score of 100, and your information processing score on an information processing tool equates a score of 65. That would be probably 2 standard deviations below your intellectual level, and you would be severely impaired. If you have an intellectual score of 120 and you have a information processing score of 80 or 85, I would consider that person also severely impaired. Now, we still don't see that picture in CFS. If somebody has about an intellectual score, let's say an IQ score of 120, I often see an information processing score of about 90, 85, 90, a little over 90. And that's a relative impairment at the about 1 to 1.5 standard deviation level. And that to me is a deficit. And you have to argue for that. Now, If we look at the next slide to move on from the relative versus
Absolute.
absolute, thank you, conversation, why are the functions, working memory, information processing, attention at a certain level, why are these executive functions, why are these more affected than other lower level functions? Well, the issue is that there is less redundancy. You don't have that much redundancy to do quick decision making, to prioritize properly, to speed up your information process. There pretty much is one area in the brain that does that, and that's the dorsolateral frontal cortex. What helps us do this generally, and I said that earlier, is that as we live our lives, we learn things, and certain behaviors become automatic. And that also extends to our cognitive function. So for instance, picture yourself in a car when you were healthy. You would drive your car. If you're a stick shift driver, you would drive first gear, second gear, third gear, back to second gear. You wouldn't even think about when you exactly shift down, when you exactly shift up, when you exactly brake. It's an automatic process. That's how your executive function should work when it's okay. However, what we hear from many patients with chronic fatigue syndrome, when they're driving a car, all of a sudden what used to be automatic is now effortful. So they have to think about it. Oh, I have to shift down. Ooh, I have to brake now. Oh, I have to put my directional on. All those things that used to be part of a no-thinking type process now become very obvious and effortful. And so they're eating away at your ability to do things fast and in an almost automatic fashion. And that automatic fashion is really, really important for something that we treasure so highly in this society, which is multitasking. If you read the paper, multitasking is it. You should be outfitted with 3 different devices with 50 million buttons, and you should know how to use all of them pretty much, if you can, at the same time. Patients with CFS have trouble with that. So this is not an optional thing to do for folks who have cognitive dysfunction as a consequence of chronic fatigue syndrome. Our world is very much geared toward multitasking, so that patients that have trouble with this, secondary to slowed information processing, working memory troubles, and executive function issues, we have to teach them how to do things a little bit differently, how to compensate for some of the lost, quote-unquote, automaticity that they had possessed before. The interesting thing also is that, and I said this before, I think, that the loss of these higher level functions is really perceived by patients as a severe impairment, because you lose some of your independence in thinking, and it's just a blow. You lose your edge in a way. So now we are really going back to what Suzanne was talking to us before, that cognitive function relies on integrated brain networks. And Suzanne, do you want to lead us through these 3 slides down here real quick?
This is a wonderful graphic that just shows the structure of the brain in this first picture, where the gray matter is kind of chipped away to show the underlying white matter. And the way we think about the brain is being this kind of blobbish looking structure that really is maybe more of a tangle than anything else. But now what we're actually finding out using these much higher resolution techniques is that it's a very fine and integrated and organized network of signals. and wiring, in fact. This center picture shows the little pink dots actually being nodes or communication hubs, and all the purple lines are actually the directions in which so many of these signals, this information is being directed. And right down the middle is where a lot of the information becomes centralized and then transmitted to the rest of the body. The far right picture is an image using, it's called diffusion tensor imaging. And this is what I referred to earlier, where they're actually now getting such high resolution that you can see the axons of the nerves. And the amazing thing, and this was actually announced about a week and a half ago, that the nerves are highly organized in parallel and in perpendicular manner, not necessarily all tangled up, again, as maybe we thought they might have been given this kind of blobbish structure on the right. So very highly organized, a beautifully intricate wiring system that needs the type of organization in order to allow for a very integrated communication system.
And there are now diffusion tensor imaging studies going on in CFS, so that should be really, really interesting.
Oh, that will be fascinating.
All right, so let's get to the crux of the matter. The common problem is the mismatch between subjective and objective reports of cognitive dysfunction. And unfortunately, clinician and the Social Security Administration, they need supporting hard findings to corroborate claims and to give a disability. Unfortunately, the evidence that is available, and some of it Suzanne presented, is in the neuroimaging realm right now, and it's really hard for either many clinicians and or the Social Security adjudicator to make much sense of it. So there have been recent reviews which I think should be read by people who either assess patients with chronic fatigue syndrome, or also people that are working in the SSA offices who are mostly not clinicians, but they often don't do so. So that's a big issue, especially and it affects I think sometimes appropriate testing. So what's the Social Security disability adjudicator looking for? The Social Security Act and our implementing regulations require that an individual establish disability based on the existence of a medically determinable impairment, for instance, one that can be shown by medical evidence consisting of medical signs, symptoms, and laboratory findings. Disability may not be established on the basis of an individual's statement of symptoms alone. So subjective report doesn't cut it. A patient with CFS is not considered disabled simply because of having the symptoms consistent with the case definition of CFS. A CFS patient has to show, the burden of proof is on the patient, that symptoms are severe enough to result in regular, predictable, or sustained limitations of even sedentary and light activities. And here I included a quote from a lawyer that I know. A case is won or lost based on the severity of your symptoms, limitations, and not on the CFS diagnosis. Winning a CFS disability case is now 10% documentation of the diagnosis and 90% documentation of impairments and limitations. Never lose sight of that crucial fact.
How does your relative deficit affect this? You know, when you were talking about relative impairment, are you going to get to that?
Yes, I'm going to get to that because that's really the job of the neuropsychologist.
Yeah.
So what the neuropsychologist has to show to convince the Social Security adjudicator of an impairment that's sustained and disabling is that it is severe enough to cause substantial reduction in previous levels of occupational, educational, social, or personal activities. And you can do that by carefully interpreting your data that you collected when you saw the patient and putting it into context. You have to put it into context. A report that you get as a CFS patient from a neuropsychologist that just sort of lists what you did is not enough. You have to write a convincing story that there is a relative discrepancy between, but a significant discrepancy, and there are statistics to do that with. So you're not totally reliant on, you know, smells like, feels like kind of stuff. There are statistics in every manual that goes with neuropsychological tests that if you are somewhat savvy with it or read it closely, that you can make a case if there is a large relative discrepancy that is a disabling discrepancy. But your neuropsychologist has to take the time to, number one, be informed about what are the profiles to look for in chronic fatigue syndrome, and as both Suzanne and I said, the evidence is congealing that there is a certain profile focusing on information processing, working memory, and executive function, and then integrate that profile clearly in an informed and well-written report. That's what you have to request from your neuropsychologist.
Does there have to be an actual formal test done, Gudrun, to show that?
Yes, because
okay.
they want objective evidence,
Okay.
and that's the only objective evidence that I'm aware of that they accept now.
Okay.
Now, I was going to talk about the neuroimaging findings. As far as I know, the Social Security office administration does not accept neuroimaging findings as evidence because these tests are not, they're still in the experimental stage as far as the SSA is concerned. Because of the reasons that both Suzanne and I told you about earlier, there are no gold standards for CFS in terms of neuroimaging, and while it may be comforting for you to know that, yep, you have hypoperfusion, so there is something going on in your brain, you're not making this up, you're not you know, just imagining things, it is likely that it's not going to help your case. So to the last slide, the bottom line of our discussion today is that patients perceive cognitive problems common in CFS as disabling. Researchers provide interesting findings difficult to aggregate in support of disability claims. Functional neuroimaging is still experimental and often not accepted as evidence of cognitive impairment. By the way, please ask your physician whether they are familiar with whether the Social Security Administration does accept neuroimaging radiological images as evidence of impairment. Ask questions. Don't just pay a lot of money to get these images done. It's expensive, and you may not benefit from it in terms of your disability. So ask your provider. They should be helping you with this. Clinicians need to be better educated about CFS to provide valid evaluations. Cost of neuropsychological evaluations is often a factor for patients. And Kim, Suzanne, and I, we've been discussing this over the past few weeks. We are going to try and figure out how we can bring a screening tool to the provider so that patients don't run into these humongous costs for neuropsychological examinations. And then finally, the Social Security Administration denies claims upon receipt of poorly argued and documented cognitive evaluations. If you go for a cognitive evaluation, do not accept a sloppy report. You deserve a well-written, well-put-together, well-contextualized report to help you and assist you with what you have to do.
How many of you are there out there, Gudrun?
Well, I don't think too many, unfortunately.
Yeah.
So,
Yeah.
So I think that the work you and Kim and I are planning is really going to be very valuable.
I think so too.
Yeah. And there are several people writing in that they've been to neuropsychologists or they are working in the neuropsychology field, and either the neuropsychologists that they've seen or their colleagues don't know anything about CFS issues or the kinds of cognitive impairments that you both have described this afternoon.
Mm-hmm.
So
yeah, so an educational issue is also probably there.
Yeah.
Do you want me to scroll on, Suzanne?
Kim, did you have one more poll before we get into the questions? I think the next one is the questions, right?
Yes.
Okay.
Well, yeah. A lot of questions about coping mechanisms, and if you guys have talked about that, I apologize. I've been busy typing. But we did have a polling question about what people do to help their cognition. Would you like to do that one right now?
Yeah, let's do that one, and then we'll just take some of the questions and
we're
last
right at
10 minutes or so.
Right. So hopefully people can see this poll now.
The question is, which of the following do you do to help your cognition? Gudrun, can you see the poll?
No, I can't. I don't know why.
I don't know why either.
So we have the choices of eat a diet high in antioxidants and or gluten-free, play brain games like Sudoku, crossword puzzles, or luminosity, take medications for pain, sleep, and or alertness, practice yoga, meditation, qigong, tai chi, etc., or I don't do anything. Those are the choices, and respondents are allowed to select one or more of the following.
And again, please don't get too caught up in what is and isn't on this list. We're limited to 5 choices and a certain number of characters in each line, so we couldn't get too detailed with this and this poll.
Which one? We had 6 before. Which one did we take out?
We took out the PT, the neuromuscular.
Oh, yeah, okay. That would kind of fit in with yoga or meditation anyway.
Right.
Maybe. There was a great piece on National Public Radio this morning on yoga.
Yes.
Yes, and Qigong is really helpful, at least for our veterans here in the VA healthcare system. And there has just been a recent study, as I said yesterday to Suzanne, by Laura Redwine in California, looking at Tai Chi, the benefits of Tai Chi for fibromyalgia, and it was beneficial. And some of these modalities can be done sitting down.
So the results are up, Gudrun, and I'll read them to you since you can't see. 53% said they eat a diet high in antioxidants and or gluten-free. 45% said they play games like Sudoku, crossword puzzles, or luminosity. 74% said they take medications for pain, sleep, and or alertness. 42% said they practice yoga, meditation, qigong, tai chi. And then 6% said they don't do anything.
That's
so
interesting.
what we should have said is, I guess that is to help. No, how helpful are they?
Yeah, that's a different question.
Yeah.
Well, so if I may, I would just like to address the medications issue and cognitive function.
Okay.
because that is an issue for a neuropsychologist. You have to take into consideration what medications your patient is on and how that affects his or her cognition. And many of the very sick patients we have are on a boatload of pain medications and other CNS affecting medications. These medications, of course, affect cognition. That is often not talked about. I'm always surprised how little patients know about the other effects of their medications other than the pain controlling ones. But they do have sometimes a sedating effect on cognition. Please ask your providers, your physicians, about these effects of the medications. Every medication has several effects, so while it's good for pain control, it may not be so good for your cognition. Now, some patients told me, well, if I would have known that, I wouldn't have felt so bad. So maybe, you know, sometimes you have to make a choice of what you need to do. But one thing we should do is we should try and put our patients in a position of control and knowledge. And if you know what a medication does to your cognition, then it's a heck of a lot better as if you don't know and you're insecure why certain issues are popping up more than others.
Yeah, the drug interactions and the adverse effects of many of these drugs is really unexplored territory, but it sure does have a tremendous effect.
It does. So just beware.
Yeah, I'm working on a study right now where we're kind of doing a medical records evaluation, and it's really mind-boggling to see the numbers of medications that many of the patients are on, and you know, I keep wondering about the types of interactions and adverse effects that these really kind of uncharted combinations can have on people.
Yeah, so I think the best advice there is ask questions. Ask. It's your health.
Okay, so let's get to let's wrap it up by addressing some of the questions that we that we got.
Okay.
Kim actually was great in putting together more than 250 questions into a couple of broad categories because a lot of them were repeated. So what Gudrun and Kim and I tried to do was address these as broadly as possible, yet really get down to you know, helping you guys understand some of these aspects of cognition. So Gudrun, a lot of questions were asked about how cognitive function is evaluated in CFS. You want to give us the skinny on that, on how you do it?
So I have two different types of evaluation that I usually do. One is a baseline evaluation. If I see a patient for the very first time, that's referred to me by a care provider, I generally do a full battery, which takes about 8 hours and includes pretty much everything: intellectual function, motor, information processing, memory, and so on and so forth. The reason I do this is to establish a deficit. You can only establish a deficit if you also show areas that are not affected. And then you know that one area is a deficit. So that's why I'm doing that. If I see a patient as a follow-up, I usually give a battery that is written up here, where I give the abbreviated ways for, then the R-bands that's repeatable, has a couple of different forms, and then I look at working memory and information processing with the CPT and digit span and so on, and the executive function in a more quick fashion. So that takes about 1.5 hours to 2 hours. I do that to just figure out whether the deficit is there or whether it's gotten better or it's gotten worse, and that helps me do that.
And there are a number of different types of neuropsychological assessment tools that your profession uses in addition to the R bands.
That's right. The R bands is not normed for chronic fatigue syndrome, so that's the caveat here. But I like it because I've done it so many times, so I have sort of an internal norm for it now, and it has a couple of different forms. So if I have to repeat the screen again in another couple of years because Social Security Administration wants to have another test done, I just use it. I like to use it. I also want to make a quick comment on, again, effort testing. And I'm not advocating for either the R bands to purchase that or for the what's it called, the VIP to purchase that. And the VIP is the validity indicator profile, and I like to do it with my patients because it really establishes whether they have put forth appropriate effort both in the verbal and nonverbal domains. And there was just a paper that came out in March that shows that the validity indicator profile, or VIP, is appropriate for testing effort in persons with chronic fatigue syndrome. So that's just a brief aside for patients and providers out there that may be helpful.
And as you mentioned earlier, as you mentioned earlier, you can go on to the next one. We're also looking at another tool to possibly examine further and get validated in a CFS population.
That's right, and Suzanne is talking about a tool that's called the NES3, and it is out there, but difficult to get for a variety of reasons. But it has been used in populations, in research populations with multiple chemical sensitivity and chronic fatigue syndrome. And so that is what Kim, Suzanne, and I are talking about, that we are going to try and make something available to the providers out there to at least get an inkling of where their patient is cognitively.
Right. And you mentioned this earlier, but really quickly, Gudrun, can you just talk about the difference between brain fog and cognitive impairment? What is meant by those two terms?
Yeah, brain fog to me means it's a symptom, it's a descriptor of something that's amiss with your cognition. You feel like you're in a bag of cotton balls, like we were saying in the beginning of the program. Cognitive impairment is really, to me, is the assessment of what that brain fog is. So that's the measurement, basically.
Okay. And we had a lot of questions on the cause of cognitive impairment in CFS, and hopefully we were able to touch on a lot of that from both the research and the clinical perspective. And as we noted, cognition is highly integrated and complex process. There's not any one known cause, but we do have some indications of some underlying pathophysiology which could be, in fact, contributing to the cognitive impairment. There were a lot of questions on treatment, and there was several questions on, do brain games help? And that was one of the reasons why we actually asked that question in the poll. And there is some recent evidence in the published literature that indicates, in fact, that these brain games do help. In other words, exercising your brain does, in fact, improve. And there was one study that was published in a journal called Brain Injury just last year that looked at children with cancer-related brain injury, and this actually used the commercial product called Luminosity. And it found that Luminosity was, in fact, effective for improving both executive and memory skills in these children. And there was actually even concurrent changes in the neurobiologic status in these children. So again, there's limited evidence, but there is evidence that brain games can help with improving certain cognitive skills, particularly in executive and memory function.
absolutely. It's like imagine an aging person, you know, healthy brain, healthy person in a way. You keep your grandmother doing crossword puzzles, and somehow she just retains that automaticity, at least a modicum of what it was in the executive function that we talked about earlier.
Excellent. There were a lot of questions about supplements and whether or not taking supplements can improve cognition. And what we did in order to address this was to search clinicaltrials.gov. This is a government site that lists all of the clinical trials being conducted throughout the world. And we also looked in PubMed. And we can summarize the supplements that are under study, either published or currently in clinical trial as listed below. There's evidence that the omega-3 fatty acids, this was actually a very large meta-analysis that was done, and omega-3 fatty acids are found in fish oils, can improve processing speed and attention in cognitive impairment with no dementia. So in other words, omega-3 fatty acids, yeah, that would be us. That would be CFS. There was no improvement in Alzheimer's dementia and mild cognitive impairment, but there was, and that's the precursor to Alzheimer's disease. Mm-hmm. There's also some evidence that flavonoids, and these are chemicals that are found in the skins of Concord grapes and blueberries. They're powerful antioxidants, that they also improve mild cognitive impairment, and I have the author listed there, Kikorian. He's actually published a number of papers, nutritional papers, nutrigenomic papers on flavonoids. There's many of you have probably heard about resveratrol, which is the red chemical, the pigment chemical that's found in the skin of grapes, again, red grapes. There's evidence that resveratrol increases cerebral blood flow, but interestingly, even though there was an increase in cerebral blood flow with this substance, there's no effect on cognitive performance. And then there are a number of studies that are ongoing that are actually testing whether or not by using these supplements there isn't a change in cognitive function, and these are theobromine, which is found in cocoa and or cacao and chocolate, curcumin, which is in the ginger family, caffeine, and vitamin D. All of these right now are in large clinical trials, not of CFS. Actually, some of them are in CFS, but many of them are in a lot of the other chronic illnesses that have some cognitive dysfunction or impairment documented. There are several medications that are also listed as being under trial under clinicaltrials.gov. And why do I have CA? Oh, I wanted to mention that a couple of our studies that we're funding are actually looking at some of the mechanistic issues that perhaps underpin cognitive impairment, both from a neuromuscular strain perspective and an autonomic nervous system perspective. You have anything to add to that, Gudrun?
No, I think that's a pretty good review of what's going on in terms of the nutraceutical stuff right now.
Yeah, yeah.
There were a lot of questions about medications, FDA-approved drugs, and I know the standard answer is for every drug that helps somebody, somebody else doesn't get help from the same medicine. Are there any other particulars either of you would like to add to that?
I mean, when I searched clinicaltrials.gov and also PubMed, I was amazed at how many clinical trials there are for cognitive impairment in general. Mm-hmm. Using 4 medications. There were, I think, maybe a handful for chronic fatigue and medications in cognitive impairment. And actually, many of the drugs galantamine is under study now in, I think it's Alzheimer's, for mild cognitive impairment. And that was actually studied in CFS, but interestingly, the outcome measure for that galantamine study was not cognition. It was probably just improvement of a different symptom. So I guess what I'm trying to say is maybe there's actually been some medications used. What were you going to say, Kim?
Well, I didn't realize you were going on with that, but I know in some of Gudrun's other presentations, she's talked about non-medicinal, non-supplement, not things you put into your body, but coping techniques like using note-taking and doing only one task at a time, and some of those little tips that might be helpful to add. I know that could be a whole topic in itself, and maybe we can do that at some time in the future.
Yeah, it's something to. It's helpful even if you have somebody at home that you could sit with and organize yourself. The things that I usually start with my patients is some patients say, I used to be able to pay my bills so easily and quickly. Now I have one big pile I don't know, and I'm in arrears here and there. Make yourself 3 different types of folders: red, yellow, green. The green for immediate, to do immediately, the red for later, or vice versa. Something so you know what to do, and make yourself put it into that folder if it's something that you have to do immediately or in the long term or in the middle term. Likewise, if you go and park in a parking lot of a big shopping mall, the old tennis ball on the antenna used to work. Try and figure something out so you can see your car. Don't be embarrassed. At least you're going to get home and you're not running around the parking lot looking for your car. Things of that nature, trying to do things a little bit less multitasking, but more serially. You'll be amazed how much more you get done when you actually do one thing after the other instead of trying to do 4 things at the same time. So these are just certain things, and by the way, this goes for healthy individuals as well.
No, it's just going to say.
Yeah, there's actually a cost analysis paper about that stuff, so I might present that at one point. In any case, there are a lot of little things to do where you can sit with somebody at home and say, you know, where is the thing that I do the worst as, where I have the most difficulties? How can we decompose that and make it serial instead of parallel? That helps a lot.
Good idea. I think that's our last slide. Gudrun, do you want to turn the controls back over to Kim?
Yeah. Okay, organizer, right? Kim. There. You're in charge, Kim.
I'm in charge. Let
I
me
just have to
try
say, Gudrun, that was absolutely 100% enjoyable. That was I learned a lot, and it was just a great presentation. Nice and informative and conversational. Good working with you.
Yeah, I enjoyed it too. Thank you. I appreciate it, and I really love doing this with you guys.
Well, if you guys in our audience will indulge me a couple more slides, I just want to direct people to where they can follow up for more information on this topic and a lot of other topics as well. I think most of the folks who had registered are familiar with our main research website, researchfirst.com, and I wanted to also make sure that people were aware that the page where we advertise this webinar has several links to other resources that could have answered some of today's questions, so you might find those helpful. As a follow-up item, and we will post the recording from today's webinar with the slides and also with some additional resources from past publications that I've been working with Kim Allman to unearth over the last few days so that we could make those available too. And also I just wanted to post or point out that on Research.com you can sign up to get the email updates so that as each new post is added, you get an email in your inbox sometime in the middle of the night to let you know that that's there, and that can be a helpful tool so you don't have to remember to go back there. Just a little cognitive tip. We also publish Research First News, which is our monthly e-newsletter. Some of you might have remembered it as CFID's Link. We changed the name and changed the format in January, and it's a free monthly newsletter that goes out generally more than once a month, actually. And then, of course, we're on Facebook, Twitter, and our YouTube channel has a lot of resources as well. So those are just some easy ways to keep up with things at maybe a reasonable pace. And then we have a couple of information, additional resources for people who support the organization. We have a print publication, and the spring 2012 issue is in production. You can see the front page of it there. And that will be mailed to donors hopefully by month's end. And we have another monthly e-newsletter called Catalysts in Action that focuses more on the people behind the scenes, both in research and at the organization and on the board, more so than research-oriented topics. We are continuing our webinar program. We've scheduled the next program. I just got this scheduled early this morning. And we're taking a bit of a different tack for our May program. Many people will know that May 12th is sort of recognized around the world as CFID's CFS ME Awareness Day, and this is actually the 20th anniversary of May 12th, serving sort of that unifying purpose. So we've put together hopefully a program that will draw a broader audience than just people interested in CFS. We have novelist Roger King coming to talk with us about his new book, Love and Fatigue in America, and his experiences as a writer living with CFS. So we're going to promote that out through some literary groups and maybe draw in a bigger audience of book lovers and somebody who'd like to hear directly from a novelist who has CFS about his experience. And he's a Brit living in America, hence the title. And we just published a book review by Jean Zimmer, who has a loved one with CFS, who has reviewed Roger's book, and that's available there at that link. So we hope you'll join us on May 9th at 2 p.m. for that sort of different take on a webinar, a less technical topic, but perhaps equally of interest. And then
that sounds wonderful.
And then, as Suzanne said, we're trying to pull one together on post-exertional fatigue and malaise, relapse, whatever term you prefer. And we'll also be doing some more webinars on the Research Institute Without Walls that was announced in February and that Suzanne and I did a webinar on in March. Just a reminder that your donations make programs like today's possible, and a link to our 24/7 online donation page if you feel so inclined after being provided with this kind of programming and would like to see it continue. And just a final statement of our mission, strategy, and core values, and we are really excited about the direction the association is taking, about the new Research Institute Without Walls, and we hope you'll take advantage of the follow-up materials that you'll be sent by email within a day or two, and also the coming programs, Research First News, and the other ways in which you can stay in touch, not only with us, but with what's going on in the field and the movement. And with that, I will thank Gudrun and Suzanne for their tremendous work to prepare for this program. As I said, I think I counted the other day, we had 12 different versions of the slides going back and forth to reflect the questions that were coming in and just the myriad information that's out there. And I think it's important just to remember that this topic of cognitive impairment is so integral to the daily lives of people who live with this illness and has been studied now for 2 decades, but is still really underappreciated in terms of its impact on quality of life and function. It really takes a huge toll on people with the illness and the people around people with the illness in terms of their abilities and ability to contribute and feel like a productive member of our 24/7 multitasking society. So we recognize that, and certainly our thoughts are with everyone as they try to cope with those things. And again, thank you all for hanging in there. We still have over 200 people on the line, even though we've gone way beyond our time. And we appreciate your indulgence and your participation this afternoon and hope that you found the program helpful. You'll get a short survey as you exit the program just to help us gauge future webinars. So thanks, everyone, and have a good afternoon or evening, depending on where you are. And we will look forward to our next time together. Thanks so much.
Thank you, everyone.
Thank you. Bye-bye, everyone.
Bye-bye.
Bye.